California Eye Center. Այսօր շատ աղոր հաղորդում ունիմ ցեզի համար իմ հետս իմ հյուրս արդեն դուք գիտեք շատերնիդ պիտեսնակ պիցեք ID imachkas viradets. Իմ հետս այսօր Dr. Mitchell Shultz. Hi,
Hello.
Dr. Shultz.
Thank you.
Thanks for making the time to join us today. I know you travel all over, you do talks all over, talking about new surgical procedures, new cataract lens options, and I know you're in and out of the surgery room all day.
Yeah.
Thank you for making time to be on the show with me today to talk about cataracts. And it's a real hot topic now, beginning of the year. People are talking about what can I do to see better, change they'd like to make. And as we know, cataracts, they don't go away. They keep getting worse. Glasses won't fix them. And ultimately, we're faced with the truth that we need to do something to open our vision.
100%.
Իմ հետս այսօր Dr. Shultzն է։ Եթե գրնանք վիդեոին երթալ, մեր website-ը երթակ California Eye Center, calicenter.com. Այստեղ կա our doctors, specialists we work with. Գտեսնակ այստեղ իրեն մասին կրված Dr. Mitchell Shultz, ինքը cataract եւ refractive surgeon է, California Eye Center-ի հետ, Shultz Chang Vision Institute-ի հետ մասնակետ, եթե հետ ստուդիո գրնանքալ, ինքը մոտ 50,000 կորզողություններ է աչքի հետ կապված, մանավանդ cataract կորզողությունի հետ։ So այսօր ինքը իմ հետս է եւ այսօր պիտի խոսենք cataract-ի մասին, ինչ է cataract-ը, ինչպես գնենք այդ կորզողությունը եւ ինչ է այդ option-ները cataract կորզողության ժամանակ այդ դարբեր լենզերու option-ները, որ քեզի բժիշկը գուտա, որ այդ որոշումը կրնակ առնել երբ որ կորզողություն ունեք։ Okay? So a little bit, Mitch, I talked about you and our viewers, and there's many people watching today, some that you've already operated on, thousands that you've operated on in our community that are watching and saying, that's my doctor. That's the one who fixed my vision. That's the one that I can see great for, be thankful for. And there's a lot right now that are patients and some that are not that have this very issue. And one day soon, they'll have to face the truth that they need to get their cataracts removed. So I think this is a wonderful show to be able to get that message out. And I think it's a great way to start. What are cataracts? Why do we get them?
Well, the important thing to understand is that everybody, if we live long enough, develops cataracts. The natural lens of our eye continuously grows as we get older, and what's happening over time is as it gets thicker and thicker and thicker, the nutrients have harder time getting into the lens, and that's when it starts to degenerate, and we can develop what are called nuclear or cortical cataracts, which cause vision problems. So here you can see on the video the lens of the eye that sits behind the brown or the blue part of the eye, and it's held to the wall of the eye by ligaments, and those ligaments are meant to keep it in place. Now there are some patients that develop problems with those ligaments. There's a very common problem in the Armenian community called pseudoexfoliation, which can cause a degenerative change of those ligaments. But naturally over time, the lens starts to get cloudier because of that thickening process. And what happens is it gets cloudier, light can no longer be focused properly through the lens. And that's what a cataract is. So it affects people at different ages. We have patients that come in that are in their 30s that have cataracts, but I'm going to say that the majority of the patients that we see tend to be in their 60s, 70s, and maybe early 80s. So here you can see the lens has gotten much cloudier over time, and when we try to focus light through it, it's diffracted all over the place. So not uncommonly, people complain about having difficulties at nighttime with glare and halos, difficulty reading street signs, and in certain types of cataracts, it may also affect their reading. One of the interesting things about cataracts is if they have a nuclear cataract, the vision for distance may get fuzzier, but all of a sudden they can read better up close without their glasses or contact lenses. And so that's something that we have to talk to patients about when we do cataract surgery, those changes in vision that happen. And we have to talk about the special different types of lens implants that we have available to them that are going to help to restore their vision. So here you can see as that cataract gets bad, we do cataract surgery, and when we do cataract surgery, we can implant a lens inside the eye. Here you can see the lens being implanted, and those new lenses are made out of a plastic material. They're not as big as the natural lens that we had, but they are designed to improve the vision.
Okay, thank you very much, Dr. Shultz. Very well put together video. Thank you. It's very clear to understand what happens to all of us.
Yes.
Me, you, mom, dad. And I always say this and I laugh. Even if you have a dog at home, even
develop
dogs
cataracts too.
Dogs get cataracts too. So cataract pamene vor ամենից բիդունենանք շատերնիտ միշտ կհարցնեն ինձ գսեն դոկտոր ինչ կրնան գնել որ cataract չունենանք մեկը չի գա աշխարհի մեջ որ 60-65 գանցնի եւ cataract չունենար ամենից կունենանք so ադոր համար պամենե որ հիմա գրնալա քեզի problem չի դար բայց աբակայում պամենե որ գրնալալ արդեն սկսիկ նկատել 60-65-ի ժամանակ ավելի problem կուտա եւ ադոնք որ ասենք շաքարի problem ունին դայբերիկները քիչ ավելի կանող կունենան որով շաքարը control չնես կատարակտը ավելի արագ կսկսի կալ so ասի պամենե որ նույնիսկ steroid եւ հորմոն թեղեր որ մարդիկ կառնեն prednisone, dexamethasone սրսկերեն քեզի ցավի համար գրնագիտ մեջգիտ այդ սրսկումները ցավազրգող շատ անգամ մեջը steroid կա որ ադոնքալ գրնան cataract առաջացնեն hormone medication թեղերը գրնան այդ բոլորը անել okay so I know the next curiosity is how do you do this surgery so I know you brought a wonderful video to show us how fast it's done 8 minutes I think
so typically an average cataract surgery takes us about 7 to 8 minutes these days. Wow, so it's pretty fascinating, and patients can get right up off the table and actually see better.
Wow!
I mean, it's
8 minutes, really, yes. And it's only one eye at a time.
Correct. For safety reasons, we do one eye at a time. While the risks are very, very low, the most common things that we're concerned about are the potential for infections or inflammation that can happen with surgery. So we like to do one eye at a time. I think it's a lot safer for patients. Make sure somebody doesn't have an infection. Make sure they don't have too much inflammation. And as long as everything's okay, we typically operate on the other eye, most commonly about 2 weeks later.
Perfect. Yes. Okay. Walk us through the procedure. And I know a lot of people are asking, I heard you can do cataracts using a laser.
Yeah.
All right, and maybe we can talk about that, and I know you brought this video here with us today.
So, yeah, we have these nice technologies, and as you can see in just a moment here, we're going to show a video. We have a technology called femtosecond laser-assisted cataract surgery. So with femtosecond laser-assisted cataract surgery, we're actually using a laser that's able to do portions of the cataract surgery for us. So one of the most critical steps of the cataract surgery is the opening of the membrane, called the capsulotomy. And here you can see the laser does it very, very fast. Actually, our newest lasers do it in less than a second to make that opening. And that's actually kind of critical for certain types of cataracts, because certain types of cataracts have increased pressure inside and can actually cause a tear of the capsule when we're just doing it manually. So doing it by laser actually helps to reduce the risks for the cataract surgery. And that's probably the most critical step of the cataract surgery. The next step is actually disassembling the nucleus. So after we open the cataract, we make this capsulotomy. We're then cutting up the cataract with the laser, so we're able to basically pre-soften the cataract to make it easier to remove the cataract, reduce the amount of energy that we use during the surgery to remove the cataract. And then we can make incisions in the side of the eye that help us facilitate getting into the eye. And the laser, again, does everything precisely, does it better than we can actually do it by hand. So those are the components of the laser.
So what's this tool here, Dr. Shultz?
So the next step that we have to use is what's called phacoemulsification, which is a high-frequency ultrasonic needle that's basically able to liquefy and then suck out or aspirate out the remaining pieces of the cataract. And we're able to do that all simply through that two tiny little incisions in the wall of the eye. So here you can see we're just disassembling the nucleus. And again, the laser helps us to reduce the amount of energy. I've done clinical trials that have actually demonstrated we have a 75% reduction in the amount of energy we use when we use laser compared to manual cataract surgery.
So at this point here, if we can go back to the video. Now the eye has no lens.
Yes.
Now, what's your process here?
So now we have to do several things. So in patients where we're using laser-assisted cataract surgery or when we're using special lenses, we actually do some extra testing called intraoperative aberrometry to fine-tune the power calculations. But once we've done that, we're then going to insert a lens inside the eye. And these lenses we place through an inserting system that doesn't require us to open up the incisions. So we're doing this through a 2 mm incision. We gently insert the lens into the capsular bag and then are able to rotate it into place. And we have different types of lenses that we use. So we have traditional lenses and toric lenses. The toric lenses we actually have to align to a specific location inside the bag. And so in these cases, it can be critical for placement. And, and like we said, the laser will help us to make it a little bit more accurate.
Okay, fantastic. Եթե այդ ստուդիո գրնանք կալ, հիմա ցեզի ցույց տվինք ինչպես կորզողությունը գնեն 8 րոպե 8 minutes գդեվե այդ մեկ աչք գնելու համար։ Երբեք երկու աչքը նույն օրը չեն գներ, միշտ մեկ աչքը գնենք, կհամբերենք, որ այդ մեկ աչքը լավ տեսնա, վերջը մույս աչքը գնենք։ Ընդհանրապես մեկ ամիս կամ 2-3 շաբաթ կախում ունի հիվանդին վրա, եթե ամեն բան օքեյ, մեկ ամիս վերջը մույս աչքը գրնան գնել։ Okay, հիմա տեսակ ինչպես աչքի մեջ լենզ տրվավ, բայց այդ լենզը ամեն մարդու համար տարբեր է։ Հadoop կորձիկներ ունենք IOL Master, որ calculation-ներ կստեղծե, calculation-ներ, որ մենք գիտնանք ինչ տեսակ լենզ պիտի աբսպրենք, որ այդ հիվանդին համեմատ այդ չափով այդ ոսմիակը տնենք աչքի մեջ։ Հիմա այդ ժամանակ, որ մենք լենզ պիտի զադենք, քնության ժամանակ մենք կրնանք հիվանդը աչքը ստուգելով գիտնանք ինչ տեսակ լենզ պիտի տնենք իրենց աչքի մեջ։ All right? So lens selection.
Yes.
How do you know what kind of lens we should be putting in the patient's eyes?
So there are a couple of important factors that we have to understand. Number one, there are the lenses that insurance covers and that patients don't have to pay a thing for. And they tend to be excellent lenses, but they're what we call monofocal lenses. And they generally work to improve the vision, but they're not going to necessarily make things perfect for people that have astigmatism or people that have previous scars in the cornea. Certainly people that have other medical conditions in the back of the eye that we have to be careful for, like diabetes, macular degeneration, epiretinal membranes. But you can see here we have several different classes of lenses. So the first one is the monofocal IOL, and that's the lens we were talking about. It's covered by insurance. They're excellent lenses. But for patients who have astigmatism, it's not going to correct the astigmatism. And for patients that don't want to have to wear glasses at all, it's not going to correct those problems either. The second class that we have are what we call toric lenses. And as you can see on these lenses, they have little marks across the lens. There's a little laser mark on the lens. And these are set to specifically adjust for a patient's eye. So somebody who has astigmatism, their eye is more shaped like a football, the surface, than it is a basketball or soccer ball. And these lenses are designed to be rotated into a specific orientation that helps to correct the vision so that we can improve their vision primarily for distance, but still necessarily wear reading glasses. Next, we have a class that are called multifocal lenses, and we have two different groups in this today. We have what are called the trifocal lenses and the extended depth of focus lenses in that category. And those lenses are really designed to give people an all-around improvement in vision, both at distance, near, and in between. Now, certain patients may not be candidates for the trifocal lenses. For trifocal lenses, we have to have a really pristine eye, no dry eye, no diabetic retinopathy, no macular degeneration, no retinal pathology at all. With extended depth of focus lenses, we can have a little bit of more tolerance for those patients, but letting them understand they may not see perfectly for the smallest print. The last lens that you see there is an accommodating lens, and that, again, it's a lens that is designed to flex a little bit to improve or enhance vision. This is a more tolerant lens for, that we can use more so in patients that are looking for distance and computer, not necessarily so much for patients that are looking for distance, computer, and up close. And lastly, we have a new category that's unfortunately not here, which are called the small aperture lenses. And those lenses now are designed to help patients that may have a problem with their cornea, like corneal scars, patients with prior retinal detachment, prior radial keratotomy, things that have create aberrations in the cornea. Even keratoconus patients, we're now going to be looking at that as an off-label use for the lens to really be able to improve vision, because it basically creates a pinhole effect that focuses light a little bit better for those patients.
Oh, excellent, excellent. The technology has really changed, and
yes,
there's so many options. And based on each patient's need and each patient's demand, we can choose the lens according to
yes,
that. For example, a lot of the older patients, they really don't drive, they're at home.
Yeah.
They might be watching TV, they might be cooking some food. So you might be making a lens decision choice based on that lifestyle. Like for example, my dad, 78 years old, he's an architect, he still works, he drives, he needs to see up close, he needs to see far. We'd probably be doing a multifocal lens for them, right? So everybody's
different.
Everybody's
and we
different.
Treat everybody based on what their needs are and based on their medical conditions. Not some patients come in and they want certain technologies and they're really not a good candidate, and we tell them no because it's not safe for their
Right.
eyes. So I think that that's another important factor.
Yes. Okay. Good. Thank you. That was a really clear explanation there. Now I'm sure everybody's here wondering, when are they going to talk about this? What are the risks? What are the risks and complications associated with cataract surgery?
Yes. So, there are some common risks associated with cataract surgery. Infection is, something that people are always concerned about. Fortunately, today with modern cataract surgery, we're using all disposable equipment, so all the supplies that we use are disposable. They're not used between patients, so the risk of infection is extremely low. Probably the most common risk of surgery is developing inflammation in the eye after surgery. So certain patients are at higher risk. Diabetics certainly have the highest risk for having inflammation after cataract surgery, and for that reason we treat with certain eye drops. We use a combination of steroids and non-steroidal eye drops to help to reduce that risk. So we can actually take that risk from about 4% down to less than 0.5% just by using those eye drops for a certain amount of time. There are other things that can happen. So, in the Armenian community, there's like we talked about at the very beginning of the show, there's a problem called pseudoexfoliation, which can cause a weakening of the ligaments as also a weakening of the membrane itself. So for many of these patients, when we're doing cataract surgery, we may have to use special devices like capsule hooks to stabilize the lens, or place what's called a capsular tension ring in the eye to actually expand the capsule and prevent it from dislocating. But over time, there is this risk of the lens dislocating, which is not something we can necessarily predict at the time of surgery. We do everything possible to avoid it, but it's something that can happen after cataract surgery. Retinal detachments, extremely, extremely rare. But what patients have to understand is the natural lens of the eye that we're taking out is between 4 and 5 millimeters wide, so it's got a round, thicker shape. That new lens that we're putting in is very, very flat, and it's only about 1 millimeter wide. And so the space behind the lens has been expanded, the volume that's there. Our body produces extra fluid to compensate for that, but still there's a change in the dynamics that over time could put patients at risk for retinal detachment. So while it's not a complication of the surgery, it's just something that can happen after cataract surgery. Also, some simple things that happen. The membrane that holds the lens can get a little cloudy after cataract surgery. So when that happens, there's a simple laser procedure that we can do in the office called a YAG capsulotomy.
We call it, we polish the lens.
And we polish the lens. We're basically making a little opening behind the lens to help clean it and restore the vision. And that's something we do in the office. Patients don't have to go back to the operating room. They don't have to take eye drops afterwards. It's a very simple thing. Vision's recovered right away after surgery. Lastly, something that can happen is vitreous detachments or floaters. So some patients don't have floaters before surgery. We look for them and we document them beforehand, but some patients don't have them before surgery and can develop them after. Again, same process that we talked about with the retinal detachments. The gel can separate from the retina, and when it does that, it can take a little piece of tissue from around the optic nerve, and that leads to a little floater that can sometimes be bothersome to patients. Generally, they get used to it. It can take 1 to 3 months. They get used to it. If they don't, there's, again, another laser procedure we can do to get rid of them.
Got it. Thank you. Yes. One last thing. How long can you wait before you remove the cataract? Is waiting too long? Can that pose a risk for you during the procedure? I mean, if it's too matured, or we say shat hasunsats, does that make it a risk? Does it become more problematic for you when you're operating in the surgery room?
So fortunately, we have lots of tools at our disposal to help make things safe. But certainly the longer patients wait for cataract surgery, the lens gets denser, it gets harder actually. And when it gets harder and we're using instruments, it can cause problems. So we can actually, it can increase the risk of having what are called zonulopathies or weakening of those ligaments. It can also, just by fracturing the lens, because when it's harder, those fragments can actually be sharpened. They can cut the capsule.
Right.
And on occasion, that can cause pieces of the cataract to fall into the back of the eye. And unfortunately, sometimes we can't get to them with our anterior segment instruments, and we have to send them to the retina specialist to remove them.
Got it.
So those are real reasons why we shouldn't wait too long for cataract surgery.
Իրեն հարցուցի հարգավ գիտեք բժիշկը քեզի միշտ կսե երբ որ հասունցած է եւ պատրաստ է գրնակ անել կորզողությունը բայց հիշեցեք եթե շատ սպասեք լենզը շատ հարսուննա շատ դժվար կլա վիրահատողին համար եւ հանած ժամանակ կնա լենզը փշրվի եւ այդ փշրանքները կրնան աչքին հետևը մտնան եւ այն ժամանակ ուրիշ երկրորդական կորզողություն պետք ունենաս որ այդ փշուրները հանեն so ադոր համար շատ սպասելը չի գարձեք լավ է շատ հասունալը լավ չէ ավելի ռիսկը կփարսացնե կորզողության ժամանակ որ սխալ բան մըլա միշտ լավ է որ համբերեք եւ ինքը դարիներ կրնադեվել 5 տարի 10 տարի 15 տարի կրնադեվե միջև հասունանա ծեր բժիշկը քեզի գսե երբ որ պատրաստ է թուն արդեն գսկաս թիմացը գնեիս այդ տարերը որ առաջ կդեսնա իր հայլի մեջ բժիշկին օֆիսը հիմա արլևս չես տեսնար, բժիշկը ակնոցը գտնես, նորեն չես տեսնար, արդեն գիտես որ տեսողությունդ կամած կսկսի որ բացիլ։ Մանավանդ իրգունները, այդ օթոների լույսերը, ասանք ասխեր կդեսնաս եզերքը, գսենք glare and halos, փողոցի անունները արդեն բրեյքի լույսերը, փողոցի լամբաները, ամեն կսկսիս քիշերները խանգարում տեսնաս։ Ադի արդեն նշաններ են որ կատարակտը կսկսի որ հասուննալ։ Բայց միշտ համբերե միջև ծեր բժիշկը ցեզի ասե որ պատրաստ է եւ շատ անգամ եթե գասկած ունիս բժիշկիդ վրա որ կրնալա պատրաստ չէ բայց բժիշկս գուզե գոր վարգան առաջ վիրահատել ուրիշ մտածումների պատճառով միշտ second opinion third opinion քնա երկրորդ բժիշկը երրորդ բժիշկը խորհուրդ ար շատ հիվանդներ եկել է մերքով որ բժիշկը իրենց ասեր են որ կատարակտ ունիք պետք է վիրահատենք եկել են մերքով տեսել եմ ես Հիմա գրնամս է 3-4-5 տարի անցերը եւ թեր հասունցած չէ։ So շատ անգամ չի գարձեք մեկ բժիշկի նսածը ճիշտ բանն է։ Second opinion, third opinion միշտ այդ խորհուրդները արեք, առաջ որ որոշում առնեք։ Okay? Thank you Mitch. This is fantastic. This is very helpful, especially these videos, these lenses, the technology, the laser, but all this is nothing compared to a skilled surgeon's hands. 50,000 procedures is not a joke. You've been doing this for over 25 years and training in Argentina, UCLA, and all these talks that you do all over the world, teaching other surgeons how to do these procedures, surgical techniques, how to get in, how to get out quick, efficient, minimizing side effects. I mean, you're definitely, I've worked with you very close for the past 17 years, and I must say you do a fantastic job.
Thank you.
So thank you for all the work you've done in our community. I know the phone is ringing off the hook, and I'm sure most of them are calling to say thank you. Not only for the cataract cases, the LASIK ones are watching too. And you've done a wonderful job, and that's another show, another day. But right now, let's take some calls, see what they have to say. Hello, ինչպես կրնանք օգնել։ Այո, live եք կրնակ խոսիլ։ Բարև ձեզ։
Մի հարցին եմ ես
Մինակ տելևիզիոնին ցայնի չեցուցեք, please։ Այո, աչքին դագը։
Աչքի տակը ուռում է, առավոտյան որ արթնանում են, տակերը ուռած է լինում և մուգ գույնի է լինում, և շաքար ունի, հիվանդը շաքար։
No problem. Televizionով կբացատրեմ. The call is for a patient who is diabetic, and in the morning when they wake up, their eyes are very puffy underneath. Gets a little better throughout the day, but it's puffy underneath. Yeah. Of course, it's an oculoplastic cock, but...
well, so one of the things we get concerned about, obviously, with diabetics, it can have kidney problems, and they tend to, they can be retaining water. So I'm assuming that she may be taking a pill or something that helps to remove water from the body, but that's very common. So the thing that people have to understand is the skin of the eyelids is the thinnest skin on the body. We're sleeping on our backs at nighttime.
So fluid moves.
Fluid just moves. And then as we stand up, it tends to go back down.
And as we get older, the collagen breaks down, so it's not able to protect the barriers. It's age-related. Դարիքի պերումով հարգավ նորմալ է որ մարմինի ճուրերը փոխվի։ Շատ ժամանակ չի մնաց. Thank you very much, Dr. Shultz. I appreciate
you.
your time. Our viewers, on their behalf, I'll say thank you as well. Kişer pari polorit, kal yerbu şapti orgu destemink.